Very good. Thank you, Claire. Thank you, Marshall, for a very interesting presentation, and for my colleagues and friends who served as panelists, many of them you'll hear from later today. It really is a pleasure to participate in this meeting. While I wish we were in Chapel Hill, which is a beautiful venue and setting for a meeting, I'm glad we can still have this at some level to still support patients, if only virtually. It really is impressive to see how far we've come over the last 17 years since Dr. George gave me my start in research back in 2003. How far we've come as physicians, scientists, treating the disease, understanding the disease, but also seeing how far we've come in supporting patients through this very difficult process, both the acute illness, but I think now even more importantly, through remission and long-term follow-up, as patients are now routinely surviving TTP. We want them to survive it well. So I'm going to talk about an issue that's obviously very important to patients, and it's relapse of TTP, preventing a relapse, and the multiple issues that surround it. We're going to handle the more specific issues and questions in the question and answer session, and I'll try to not take up too much time, because I think the most important part is the open discussion. But I want to lay out some of these issues that are important to understand the discussions that we're going to have about relapse, preventing it, the risks for it, things like that. So Marshall's already talked about this, but it's worth highlighting again, this acquired, or the correct term, immune-mediated TTP. In the top part of this slide, you can see that long string, which represents the von Willebrand factor being secreted into the blood vessels. So right into the blood vessels it goes. And these Adam TS13 protease, these triangles, the job is to cut that from very large pieces into the smaller pieces. The job of this VWF is to be the glue that sticks platelets to the blood vessel when there's a hole, a defect, a cut, things like that. So it mediates clotting where it's supposed to, but not where it's not supposed to occur. That process needs to be controlled. If you look at the bottom part of that slide, where you don't have the Adam TS13 protease, this could be because you developed an antibody against it to clear it, to block its function, or if you're a congenital patient where you're born without it, you don't cut those pieces. So these big pieces will circulate, and instead of just forming clots where they're needed, they'll form clots all over the body where they're not needed. And that's sort of the pathological extension of a normal and helpful physiologic process. Next slide, please. So there was a recent publication sponsored and supported by the International Society of Thrombosis and Hemostasis. So this is a large association, governing body for hematologists that helps to put in annual meetings, support research, patient support efforts as well. But they sponsor the production of what are called treatment guidelines. And not enough time to discuss the specifics of them, but these are guidelines that have a methodology that are standard in the field that are applied to different diseases. They are intended to have a standardized way to look at the scientific evidence and have experts in the diagnosis and treatment of the disease, as well as experts in different fields that deal with it, sort of assess the information and make recommendations. These are recommendations that are thought to be and hope to be unbiased and just based on the scientific literature that supports it. As a part of these guidelines, so these guidelines cover the diagnosis and treatment of TTP. They're very interesting. They're very, very long and detailed document. But as part of these guidelines, they also put in what are called good practice statements. So these are ideas, thoughts from experts in the field, consensus on important things that need to be done or considered by physicians that don't necessarily have a study to back them up. But they're based on strong opinions from experts in the field that think this is important. And two of the things you're going to hear more about today, long-term complications, and as we'll talk about here shortly, the Adam TS13 activity monitoring in remission, are two things that are felt to be important and were commented on in these good practice statements of the treatment and diagnosis guidelines for TTP. Next slide, Claire. So along with the statement that these are important and the specifics, we'll dive deeper into this ADAM-TS13 activity monitoring and remission, because it's a very important issue in the field for patients, especially who are aware of this, as well as physicians. And these good practice statements stated that the ADAM-TS13 activity should be assessed regularly during follow-up. Very clearly, they are a risk factor, and we'll talk about here in a little bit, a risk factor for predicting the risk of relapse. There's not great long-term studies and well-done prospective studies to say absolutely what's the most effective way to monitor patients. But the guidelines suggest in general, after an acute episode, patients should be monitored every month, at least for the first 3 months. We'll see patients weekly for the first month, monthly for 3 months, every 3 months for the first year, and then that interval may decrease to every 6 to 12 months. Again, these are guidelines that are based from just good practice statements, expert opinion, and may change in the future with better studies. It's also important to note that there is a frequency to measure these ADAM-TS13, this testing, but you also, as we'll talk about here shortly, measure it more frequently if it seems to be declining. And we'll talk about that here in just a little bit. Next slide, please. So this is a research study that was published now a couple of years ago. I think the credit did not show through with the background, but it's from the Oklahoma group, and looking at 2 different cohorts of patients. So these are patients that were diagnosed and treated, I believe, with the first ever diagnosis of TTP. And the ones in the dark line did not receive rituximab as a part of the initial treatment, and the dotted line above did receive the rituximab. On the left axis going up, where it says relapse-free survival, you can see the percent, and it really is what it sounds like, relapse-free survival. So when you go down across the bottom axis where it says years, you can go up to each different arm of the study, whether they got rituximab or didn't, to see the percent of patients that were relapse-free. So if you look at about 50% of patients are going to have a relapse, and you can see about the time that happens. In the dark line, it's certainly the no rituximab patients. So at 5 years, roughly, you can see around half of patients have suffered a relapse. Seems to be most common in the first 2 years. But as you see the curves going down, and the curves going down are indicative of ongoing relapse, you can see relapses can occur even at a late date. But one thing I think you can go back to that slide, I'm sorry, Claire. One thing you can clearly see is the line drops sooner and lower in that solid line where they did not receive rituximab compared to the ones they did get the rituximab. Certainly starting to suggest, as other investigators in the field have, that rituximab can at least delay a relapse of TTP. And we'll talk more about that here in a little bit. Now we go, next slide. So along the same lines, this is work that was done by our group at Ohio State now about 11 years ago. And it's a bit busy of a slide, but I'll talk you through it. And what these are representing, these are studies done in about 35 or 40 patients, if I recall correctly, who had the ADAM-TS13 activity measured every 3 months. So that's been the convention in our program. Every 3 months they're measured. And this study looked at, in those patients who had it measured, based upon their activity, did they relapse in the next 3 months or not before it was measured again? So this model is looking at what is the risk of relapse compared to the ADAM-TS13 activity. And that top panel you can see, as you move to the left on the bottom, you see the ADAM-TS13 activity going from 0 to 100%. And this is in all patients. And as you look, so going from right to left on that bottom axis, you should see activity goes down, the probability of relapse goes up. But what might be surprising to many of you is the relapse risk in all patients is really not that high over the next 3 months. It starts to approach 10% in the next 3 months. You've heard others talk about other factors, and certainly there are other multiple factors that we're still trying to learn about that are important to predict relapse. Just look at age. So in this bottom column, if you look at the dashed line, the darkest one, it's a little hard to follow and I don't have a pointer, but the very bottom line shows you the patients over age 60. The very top line, Claire's trying to help out, thank you. That real small dashed line is the patient's age 20 or higher. So what this is showing is this risk of relapse over the next 3 months based on their ADAM-TS13 activity, but that risk is different depending on your age. The younger you are, the risk of relapse seems to be higher. And in this study, it looked like the risk of relapse as you got to undetectable ADAM-TS13 activity started to approach 50% over the next 3 months, which is a fairly significant risk of relapse. So I think this is a good example of looking at the ADAM-TS13 is important, but there are multiple factors that are important that all need to be considered that will factor into, do you relapse or do you not relapse? Next slide, please. So the question's been asked many times, why would I relapse or how would I relapse? And there are several different scenarios that may account for this. You might have an antibody that goes away with your treatment with plasma exchange and steroids, but now it comes back. And there's something about you as an individual where a lower ADAM-TS13 activity is more likely to cause a relapse. What also could happen is that there's something else that triggers a relapse in a patient who is already ADAM-TS13 deficient. And we'll talk about this in an upcoming slide in the diagnosis of congenital TTP in pregnant women. So there may be people who are ADAM-TS13 deficient, but yet something else has to happen. And you've heard this before from Marshall and others. There's a second hit that has to happen. So it seems to be that there's ADAM-TS13 deficiency that sort of sets the stage for relapse, but something else has to occur to trigger that relapse, this second hit. We call it a second hit in the field. Other people will call it more specific things, pregnancy, infection, medications. There are a lot of things that potentially could do this. So in the right context, a low ADAM-TS13 activity, the second hit that occurs can lead to an acute TTP episode. And it may need both of those to occur for a relapse, for a TTP event to occur. And the other thing that's important to consider, when you measure patients' ADAM-TS13 activity every 3 months, that gives us the ability to predict the risk of relapse. But just because your ADAM-TS13 activity may be normal, or it might be slightly low at 35% on the 1st of September, something could happen on October 1st that we're not aware of, that before it's measured again, could lead to both a drop of your ADAM-TS13 activity, as well as lead to a second hit that triggers the development of TTP. So the important message here is the ADAM-TS13 is very important, but it's not the entire story. And you have to keep that in mind as we discuss these issues going forward. Next slide, please. So as an example, and I won't bore you with too many details, but the scientists and researchers tried to study diseases. They try to create animal models because you can do things, obviously, to animals in a research lab that you can't do to patients. And one interesting thing done now many years ago was to create a mouse that did not have the ADAM-TS13 protease. So the idea was you create a mouse who doesn't have ADAM-TS13, they would develop TTP, and you could study treatments, you could study the disease, you could study how it affects organs in mice. Fortunately for the mice, unfortunately for the researchers, these mice who did not have ADAM-TS13 activity did not routinely and reliably develop a picture that looks like TTP in mice. They actually had to use shigatoxin, collagen, which are different proteins and enzymes and toxins that can occur in the body, to initiate the development of the thrombocytopenia. So they had to actually give this second hit to these mice who did not have the ADAM-TS13 activity to then reliably create the disease, to then study the disease. Next slide, please. So I think this is an interesting study from a colleague of ours in France, Paul Capo, and his French TMA group that I think will help to illustrate this. What they looked at was 519 patients who were diagnosed with TTP as adults. They looked at 42 of them who had their first episode of TTP when they were pregnant. So step back, I mean, pregnancy is known to be a risk factor for the development of TTP. So someone who has deficient ADAMTS13 activity, if we knew that going into a pregnancy, we would suggest and predict they've got a very high risk of developing TTP during the pregnancy, typically in the second or third trimester. But in this study, they looked at 42 women whose first TTP episode happened when they were pregnant. And what they found, 10 of these 24 were actually diagnosed with congenital TTP. So step back again to see what that means. These 10 women out of these 42, 24 of these patients diagnosed with TTP during pregnancy the first time, 10 of them had congenital TTP, which means they've lived their entire life with this low ADAMTS13 activity, but yet didn't get in trouble, develop the disease clinically until they became pregnant. So in this human model, if you will, they are born without the ADAMTS13 activity, and it's that pregnancy that serves that second hit to develop their first congenital TTP episode. Next slide, please. So we've talked about the fact that the ADAMTS13 activity is certainly a risk factor. But should a low ADAMTS13 activity alone be treated? That's a very important question. Some things that we know, and I think this will serve for be helpful for our discussion that comes and that follows here. But that's stable and durably stable, meaning ADAMTS13 activity that is normal during follow-up and stays normal, is reassuring and predicts a lower risk of relapse. We also know that persistently low levels of the ADAMTS13 activities, especially less than 20%, does not mean absolutely relapse is going to occur, but identifies patients who might be at increased risk for relapse. We commonly look at patients who have low ADAMTS13 activity and have already developed relapse as sort of a surrogate for identifying somebody who may be at greater risk of relapse. So until we get some better models and data to point out exactly what that risk might be, patients with low ADAMTS13 activity and a prior history of at least 2 episodes, so you had to have one to start out with and a relapse, we might look at as a greater risk and be more apt to treat. But some more things you have to remember, and things we've learned and other investigators have learned over the years at following patients for many years. Fluctuations and variability can and will occur, and will occur above and below this 20% or 10% threshold that you want to use. Trends, therefore, are more important than one measurement alone. And as with a lot of things in medicine, you need to balance the risks and benefits of treatment. And that's really the discussions we have. The risk of rituximab, the risk of a splenectomy that we'll talk about briefly, the risk of any other immune suppressive medicine, balanced against the risks of a relapse of TTP. So you're looking at the benefit being preventing a relapse, the risk being the side effects from these potential medications. Next slide, please. So if we get more specific, and I've already mentioned this a little bit. So in that activity, we used to say 10%. Now it's probably more common and more reasonable to say 20%. When it is less than 10%, there's an increased concern for relapse. Again, relapse is not absolute. It's not uniform. You don't develop undetectable activity and develop a relapse. But again, as I mentioned previously, patients with a prior relapse history, we may take this a bit more seriously. We may be a bit more concerned and may be more willing to treat that ADAMTS13 activity in somebody who does not have active or known active TTP. Again, the activity that's normal in remission is comforting. The 20 to 65% is a bit unclear. The trend is more important, and we think this is where serial monitoring to determine that risk may be more important. Again, the trend more than one particular measurement is likely more important. Next slide, please. So these are additional data from the French group. Let me move my picture here. That show really kind of demonstrate where the field has gone over the last several years. And the term has been used as prophylactic rituximab or preemptive rituximab, trying to treat patients with low ADAM-TS13 activity prior to the development of a clinically apparent TTP. So these are patients that are followed every 3 months, and when the ADAM-TS13 activity is low, they're retreated. Maybe I should have mentioned this earlier, and I apologize. Rituximab is an antibody against B cells. It clears these B cells that produce antibodies in your body, but also produce the antibodies that will clear and inhibit this ADAM-TS13 protease. It's given in 4 weekly infusions, and in general, we think the effect is transient, not permanent, meaning we don't think this quote-unquote cures the disease, but it clears the B cells with the hope that it'll take some time before the B cells can return and start producing these same antibodies. In some patients, they won't. In general, 1 to 3 years is the range. Many patients will fall around that 2-year mark where the ADAM-TS13 deficiency can recur and may or may not need to be treated again. In this study, the French group used the ADAM-TS13 activity to retreat patients when they dropped again. And you can see the historical controls they used, which are previous patients that were followed with ADAM-TS13 activity and not treated with rituximab, and the more recent patients in red who received the rituximab. If you look up that left column, that left axis, again, same thing that we used before, this relapse-free survival. So the lower you go, the less % chance you are relapse-free or you have relapsed. And as you can see, the blue, the non-rituximab patients seem to have a shorter relapse survival over time. Relapse-free survival, I should say. So they are relapsing more often than the rituximab-treated patients. So very clearly, with treatment of TTP patients with rituximab, ongoing treatment in remission to prevent or treat this ADAM-TS13 deficiency, you can prevent relapses in many, but not all patients, as you can tell. The line still goes down. But does it fewer relapses mean less long-term complications? That's sort of thought by many people. We like to think that, but the data so far don't seem to support that. Meaning one episode in the wrong way could have the same implications on short-term memory issues, mood disorders, than somebody with multiple episodes. It's not very clear. Does preventing these recurrent episodes improve survival? And I think that remains to be seen. That's certainly something that may be possible and may be something we see. But longer term follow-up of these initial patients is going to be required. Next slide, please. Just to mention this, we're going to talk a lot about rituximab. There are other medications that have been used, cyclosporin, bortezomib. Many may ask questions about them. But keep in mind, the spleen is where you produce a lot of antibodies, where these memory B cells may live, that sort of live and continue to produce antibodies, and may also be a site of destruction of different cells in the body. Splenectomy used to be a treatment for TTP many years ago. It used to be used early in my career for refractory TTP. It's now known and thought that treating an acute TTP episode with a splenectomy is not likely to be effective, and you're going to have more complications associated with it. But doing a splenectomy, so removing the spleen, an organ that produces antibodies and may house these B cells that can persist in producing these antibodies, may have a significant benefit. So this is, again, a retrospective study, meaning these were the practices that were done. They looked back to see how effective they were. So this wasn't planned ahead of time. And what they found in patients who underwent splenectomy, in 24 patients who had a splenectomy for relapsed TTP, so to prevent future relapses, only 25% relapsed after a median follow-up of 15 months, with some being followed as long as 96 months. There was certainly a decrease in the number of relapses per patient year. So certainly suggesting that a splenectomy might prevent relapse. This certainly needs to be studied better. It's getting more discussion in recent years. I'm not going to tell you it's better, the same, or worse than rituximab. These are things that still need to be studied. But but it's certainly one potential option. It needs to be looked at going forward. I think that's very interesting. Next slide, please. So things to remember as we go into a discussion here on relapse. A low ADAM TS13 activity does not automatically lead to relapse. So it's not uniform. We think of it. The ADAM TS13 activity, I would tell you, is not the answer, but really the beginning of a discussion. And I don't want people to get too focused on just that number. It really is that number in the context of the patient, different factors that might affect their risk with a particular treatment, their risk of surviving another acute TTP episode. So again, we're balancing the risk of treatment versus the benefit of the treatment, which is preventing the relapse. And I think you'll hear a recurring theme today that what happens next depends on the preferences of an informed patient. So again, this activity is the beginning of the discussion. We'll talk about what we're going to do with this before we even order the test, which I think is the right way to do it. We'll talk about it as a risk factor. We'll talk about it as we're not going to get too upset if it's low, but it's going to help us manage the risk going forward. As you've heard before, you'll hear again, clinical trials are important tools to help us understand these questions, to see what happens with a patient who doesn't have normal ADAM TS13 activity and someone who does. What happens to them going forward? Next slide. So what is coming up next? There's already work from our institution and others and people we're working with, our consortium working with around the world to come up with better prediction models. And I think the answer here is going to be additional biomarkers or blood tests to improve the accuracy and prediction of relapse. You know, just the ADAM TS13 activity alone is helpful, but there are other factors. And there are certainly patients who have low ADAM TS13 activity who don't relapse like other patients who do. Age is certainly one factor. Ethnicity may be one factor. But these are things that need to be sorted out going forward. And again, I think better treatments to prevent relapse. We need to understand better who responds to one treatment over another. And as you saw from some of the work from Dr. Mazeppa and our consortium, race mattered in terms of response to a specific treatment. And I don't think we should be surprised by that. Well, thank you very much for your attention. I think Claire's going to do some juggling and get a panel discussion going.
Yes, I'm going to bring up our panelists now.
Had to go to my glasses. Slides got small. My eyes got old.
Okay, we have a lot of questions here.
Claire, why don't we start by having everybody just introduce themselves and where they're from?
That works with me.
And I see Camilla first. Camilla, why don't you go first?
Sure. Hello, my name is Camila Macias, and I am a hematologist working at Baptist Health in Miami, Florida.
Good. Ming, go ahead.
Hi, I'm Ming Lim, and I'm a non-malignant adult hematologist at the University of Utah.
Anna, your turn.
Good morning. I am Anna Antun. I am one of the hematologists at Emory University, Atlanta, Georgia.
Thank you. And Satish, go ahead.
Good morning. I'm Satish Chon. I'm one of the pediatric hematologists, also from Emory and from Children's Healthcare of Atlanta.
Very good.
Okay. Our first question was actually brought up in the last session, but I saved it for this one. This patient's been in remission for 1.5 years and the platelets are good, but the ADAMS TS13 is very low. Does this mean a relapse is coming? So I know you addressed this with the second hit theory, but if you want to go ahead and just talk about it a little bit.
Yeah, I'll just answer it real quick, I think. So the answer is it is a risk factor. It's not the only risk factor. And a lot of things all have to be considered. I think a relapse history is important. Right now, I think the best we can do is a patient who has had multiple relapses, or at least one relapse, demonstrated this relapsing disease phenotype, we say. A relapsing phenotype with low ADAM-TS13 activity suggests the relapse risk is increased and would warrant the discussion of rituximab, cyclosporin, other treatments such as that to prevent relapse, with rituximab being the most common. But it's a discussion, I would say. It's not an absolute either direction.
Do you have any idea what might cause the difference in levels of severity of the disease, or why certain people will relapse and others won't?
Camilla, why don't you start with this one? You did this, you published this before.
I think as Spero was saying, a very well-known risk factor for a relapse is a persistently low ADAMS-TS13 level, activity level. And we don't really know why some patients will have a drop in their ADAMS-TS13 activity versus others maintain a steady normal or somewhat normal level. But as Shruti was saying on the other talk, you know, this is something that we're working on. There's a lot of uncertainties as to answer your question precisely. We're not quite sure as to why some people relapse and some others don't. We know that the ADAMS-TS13 activity is a risk factor, but there's other factors to consider, sort of what it's been discussed before this second hit. So if, for example, you know, a patient gets pregnant, as we'll discuss before later, or has a severe infection, something that may trigger something else, those patients will be more prone for a relapse.
Well, you published this before. Why don't you just talk briefly about the difference between a newly diagnosed and a relapsed patient and how they might show up to the doctor?
Yeah. So, you know, there's an idea that patients that already have a diagnosis of TTP, they will be able to recognize their symptoms earlier, and they will be able to say, hey, maybe I'm bruising, or I don't feel well, I have a headache, and that is going to prompt them to come to the hospital sooner. And that way they're going to have sort of a faster or a not so severe episode in the relapse episodes when we compare them to the first initial episode. However, when we've looked at the Ohio State University patients and we've compared the patients that presented initially versus the patients that presented with a relapse and tried to identify if there was really a difference in their outcomes, we found none really. So even though patients know sort of their warning signs and they may present earlier with not so much of maybe their platelet count is not as low, but ultimately the mortality associated with each relapse is the same as with their initial episode, and the same goes for the morbidity, so the time spent in the hospital.
So we're getting a lot of questions about rituximab, about the difference in the dosages, so whether they get a single round, whether they get 2 rounds, whether they get the full 4, how long is it effective for, what are the side effects you're seeing with rituximab? So who wants to talk about rituximab?
I can start. Can you hear well?
Yes, I can hear you.
Very good.
So regarding rituximab, there is, we are using the doses, or I am using the doses for the initially did for patients with lymphoma. So those is the full dose every week for 4 weeks. There is some data in patients with especially rheumatological diseases that they use lower dose of rituximab, but at Emory we use the full dose weekly for 4 weeks. How long it lasts, the effect of rituximab, it varies, but is approximately 6 to 9 months. And this is why we need to monitor the Adams TIA13, because once the effects, if we give for preventive acute events, then every 6 to 9 months, we need to repeat the dose if needed. This was the question. Did I miss a part of the question?
No, that was good. So it's just, what are the differences in the dosing that people utilize for rituximab? How long do you see rituximab be an effective measure? And if a patient's Adams TS13 is below 30%, would you start rituximab or would you do it sooner? So those are all the topics that have been asked.
Okay.
So I guess who would use?
So one more thing, can I say something? So there was a study in Washington University, WashU, that they used the low dose of rituximab for patients with TTP. It was a pilot study, means that they used very small number of patients, and they didn't notice any difference between the low dose and the high dose. But bigger studies needs to be done, but this was a study done. So as an information.
I think that also I wanted to clarify, I think that for TTP, there's 2 indications for the use of rituximab. One is when it's used in the acute episode in combination with steroid and plasma exchange. And that is with the hope not only to prevent relapses, but also to prevent exacerbations from that first acute episode. And then the other indication that I think most of the questions are coming is to when used in asymptomatic patients that they're just being followed in the office and they notice maybe a drop in their Adams TS13 activity level, but otherwise they're asymptomatic, all their other labs look great. And that's a preemptive use or something that we use in the hopes to prevent a future relapse. And I think there's a lot of maybe controversy as to some centers use them, in all the patients that start dropping. At Ohio State, I think that Spero uses it after a patient has had 2 consecutive severe deficient Adams TS13 activity level, but every patient is different. We'll have patients that, they never recovered their activity, and they had 1 episode of TTP and we follow them for years and years and they never have a second one. So maybe in those patients, giving them rituximab, it's really not worth it. Whereas other patients, they do recover their level and then all of a sudden they drop. And in those patients, we consider rituximab.
One thing I would throw in there real quick is, you say the Adams TS13 activity is 30%, but I would wonder what it was the time before. So you get a different answer, right? If it was 50 or 60 3 months ago, 30 might concern me a bit more. But if it was 20 3 months ago, I might feel a bit better. So again, it's the trend, not just one that you need to use to address these questions accurately.
And I'm just going to add on with the trend. Again, everyone's a bit different on at what level you would start using rituximab. But I think most people, if they were to use rituximab in an asymptomatic patient to prevent relapse, most people would not be using the full rituximab dose, as in what Dr. Anton had mentioned, once a week for 4 weeks. I've had good successes when I've used it where I've only used 1 dose and then I see the Adams TS13 come back up again. So that's the difference in dosing between the acute stage of treating TTP and the prevention stage.
And why would you guys, or would you utilize high-dose steroids as a prophylactic treatment for a patient who's in remission? They're asymptomatic, but their Adams TS13 is on a steady decline. Would you utilize high-dose steroids, or would you look at a different treatment? And why would that be?
She thinks you're a pediatrician. You're uniquely qualified to know about steroid side effects and why you stay away from them. You answer that one.
Yeah, no, I think it's a great question because especially from a pediatric standpoint, as Dr. Cataland earlier showed a graph about that some of the younger patients tend to slightly have an increased risk of relapses. Our general trend and practice have been to actually use rituximab upfront, mainly so as so many questions have been alluded to or asked about the risk of steroids, especially long-term with relation to growth, brain development, and also subsequently additional immune suppression. The reason some of these patients who have acquired TTP have underlying lupus manifestations. So one, it may suppress the obvious presentation or more of a better evaluation of these patients, especially if you're using high-dose steroids. And also a lot more of long-term side effects that has come out. So hence we try to stay away from using high-dose steroids, preferably if you can get away from using rituximab, as other panelists have alluded to.
So here's another good question. Would you consider a patient who is asymptomatic but had a drop in their Adams TS13? They did get treatment with steroids and rituximab. Would you consider that a relapse? Would you call that a relapsing patient if they didn't have any symptoms other than the drop in Adams TS13?
Ming, go ahead. You take this one.
Currently, based on what we define as a relapse TTP, just a drop in Adams TS13, we would not consider it as a relapse TTP at this point. But it would suggest to the provider that we're going to monitor you more closely, keep an eye for any signs and symptoms that you think could be a presentation of TTP.
So what's the rate of relapse for those in remission, and what do you typically see? I know, Spero, you had some graphs there, but do you guys have a statistic or a number that you typically will let patients know about?
I mean, I think it's a fair statement to say half of patients with immune-mediated TTP are at risk of relapse. But to say how many relapses, how often, when it could occur, it's more difficult to say. And I also would add, you know, if we're going to say, and I believe that Adam TS13 is a significant risk factor, along with other things that are being discovered and studied right now, I don't think you can say your risk of relapse is static. It's not the same at diagnosis, your first remission, and 2 years later, as things unique to your own person change, your own physiologic processes change. So as the Adam TS13 changes, your risk changes, as well as other risk factors as well. So it's a fluctuating thing. And I think the evaluation of risk in a patient as we're going forward is going to be something that's in process and changing constantly and assessed.
Here's a good one for Camilla, because oh, sorry, go ahead.
Go ahead, Anna.
No, I'm sorry. I think it's also patient dependent, because some patients relapse more often and some other patients no. And the timing, I have patients that relapse in 1-2 years, but other patients that relapse in 10 years. So I think it's important that each patient is different. Mm-hmm.
That is that discussion you have, that their tolerance of being treated with rituximab and that risk versus their tolerance of another acute TTP episode. Most lean toward not wanting that acute episode, but there are different decisions that people make for different reasons.
So here is a good one for Camilla, because like I said, she'll be talking about this later, or Anna, either one of you, because you guys are both doing this talk. Do you recommend not getting pregnant because of the high risk of relapse? Or how should women of childbearing potential who may want a family handle the risk of relapsing with TTP?
Yeah, I think, you know, that's why we'll have a sort of a small session on women and TTP, because there's certainly a concern for women on childbearing potential about getting pregnant. But the truth is that I think about half of the cases of adult immune-mediated TTP will happen in this population. So it's something that we'll address at length later. I would definitely not recommend someone not to get pregnant because of a prior diagnosis of immune-mediated TTP, to answer your question. But there's several things that we need to consider when someone wants to get pregnant, and what would be the appropriate follow-up for these patients. I think that, just to add that our ultimate goal is for everyone to live at their, all their potential, and that's certainly something that can be achieved. It just needs a closer follow-up.
You need a motivated patient, an informed hematologist, and high-risk maternal fetal medicine OB to help out.
But it's not impossible.
No, it's certainly possible. It's possible. It just takes a team effort and some planning, like many other issues in pregnancy. No different with this.
So this patient was prescribed mycophenolate for an acute episode they had in May of 2020. How long do you typically keep a patient on mycophenolate, and how is it utilized to help patients recovering?
I guess I can take this. So there is not a tremendous amount of data for some specific immune suppressive medications. So it's difficult to really make an informed decision. You'll see this with older medicine.
Spero, I think you're cutting in and out there. Your connection might be bad.
Should I start over?
Oh, yeah, I think you're back now. Go ahead and start over.
No.
Nope, you're gone again.
So
hold on, Spero.
Have somebody else do it. Yeah.
Yeah, we'll have somebody else jump in real quick. Does someone else want to jump in and talk about mycophenolate for us, please?
Yeah, I can start. I can continue or start. So there is not too many information about the use of mycophenolate in the treatment, but once, in my opinion, when the patient is in remission, one of the important points when we are going to stop or continue will be the side effects of the medication. That if the patient is doing well, we will continue to avoid acute events. I don't know if anybody has other opinion.
I think that mycophenolate is one of the few medications that are used to prevent relapses in patients with TTP, in the same way as cyclosporine, which Spero talked about, and azathioprine, I think other centers use. And yeah, like Anna said, I think the decision to stop depends on not only on the side effects, but also on the patient's history, the number of events he or she had before of TTP.
Am I back?
Yeah, you're back.
So I would throw in that this risk-benefit discussion we talk about happens when you start the treatment. It happens all through the long-term follow-up, using the ADAM-TS13, which is usually what you're targeting the effect of the medication, which is what you're doing with mycophenolate, with the side effects the patient might be having, and trying to use the least effective dose, we say, to get the expected benefit. Again, limited data, but that's sort of the approach. And that's just like the risk, the benefit can change over time.
Okay. So the next set of questions have to deal with ADAMS-TS13 monitoring. So how often would you monitor? I know, Spero, you went through and listed your schedule, but for the other physicians on here. And then is there a risk of having too high of an ADAMS-TS13, so over 100%? And in countries that they don't have access to the ADAMS-TS13 test, what do you recommend they do to monitor? So any of those topics, if anyone wants to talk about.
I can start. So Spero gave a very good outline on monitoring of ADAM-TS13, and I do follow the same criteria recommendation. I would say that in the first month itself, when I'm still tapering patients off their prednisone because they have gone into remission, I likely would check the ADAM-TS13 about once a week for the first 1 month and then space it out. Again, it's very dependent on the trend of the ADAM-TS13. So if the ADAM-TS13 is coming up very slowly, I may still continue doing it every week for longer than that. But if I see the ADAM-TS13 has normalized completely to about 100%, then I may back off a bit. But I would still do it every 3 months for the first 1 year itself, just to keep a very close eye on the patient. I'm going to have to defer the question on what to do with testing in places that don't have access to ADAM-TS13.
Yeah, there really is no good substitute for that in the field. You know, you can monitor the platelet count, the LDH, but once the platelet count drops and the LDH goes up, an episode's already started, then you're out of the prevention mode, you're in the treatment mode.
Claire, did the person that asked the question, did they ask where are they from?
I did not see that in there, but let me check.
Yeah, that's a good point, because it may not be available in your institution, but there are very good labs, commercial labs who actually do this testing on a regular basis. And it's important to be done by labs who do this on a regular basis, especially to identify these low levels and also subsequently look for antibodies if present.
Yeah, if they are in this country, so always they can come to the university's hospital once or twice a year, and we can check the levels if it's possible. We don't know the circumstances, but it's an option.
Yeah, the question was, what can you do to prevent and control in countries that do not have Adams TS13 tests?
Oh, in other countries, okay.
Yeah.
That's a bit more difficult. You're flying more blindly. You really don't want to start doing things. In general, if you're going to have rituximab, you're going to have the ADAM-TS monitoring in general. That may be not true everywhere, but those are two things that may be consistent in healthcare systems. But it's hard. The idea is to try to expand access to this testing for everybody to be able to do these things.
And so for a physician or for a patient who has a hematologist who doesn't want to monitor the Adams TS13, who doesn't feel as though it's necessary, would you recommend that the patient stresses the importance of the Adams TS13 to the physician, or how would you handle that conversation, or how should the patient talk to the physician about that?
Sure, I'll take it. I think it's a great question. It's important to also recognize that not all hematologists take care of these rare diseases on a regular basis, and not everybody is comfortable or up to date. So I think sometimes it's not necessarily that they don't want to, that they maybe not aware of it. So I think it's certainly a good idea to have the discussion, an open discussion with the physician, always. And I think, like I tell all my families and patients, that one, knowing about the disease actually makes you the best provider, especially from a parent's standpoint, because I'm a pediatric hematologist. And it's important to have the discussion. And also I encourage my patients to read papers or go to a website so that they can come back with questions. And that will actually also stimulate the physician sometimes to go back and look up. And if it's like I think somebody alluded to earlier, that if you're really having a tough time being able to convince your physician, maybe you can go to a nearby university hospital or email on the USTMA if that's something that can be done, and certainly look for other answers.
Yeah, I agree. I think it's perfectly fair for a physician to say, I don't know exactly what to do with this. I don't have the experience, and I don't think I should order it. That's fair. But then they should be able to be referred to a tertiary care center or somebody who has more experience with this. So I respect the physician who doesn't want to order something they don't know what to do with. But that also demonstrates the knowledge gap you either have to close yourself or refer to somebody else to get some help, because it's a complicated field, as every field of medicine is.
So here's an interesting question that I feel like we're looking at right now. Can damage occur from TTP while a patient's in remission? For example, can kidney damage occur while the Adams TS13 may be within what's considered a normal range, or occur during a relapse? Can that be from TTP? So basically, are there silent episodes?
I think that the long-term complications that we're seeing in patients with TTP are not only related to the number of episodes they've had. So we have patients with one event, one episode of TTP, and then we follow them for many years, and we do see a higher risk of high blood pressure, some kidney damage, and then some memory problems, anxiety, and so the reason to monitor patients after their initial diagnosis is not only to prevent relapses, but to monitor for these long-term complications. And sometimes what we consider normal Adams TS13 activity levels, there's a range of it. We know that with more than 10%, the patient hopefully will not have a relapse, or more than 20%. But they are more prone to these other long-term complications from the disease, especially when their Adams TS13 activity level leads sort of in the lower range of normal, like around 30 or 40%. There's a lot of studies going on on that subject.
Just to add to that, it also depends on what's maybe causing the immune TTP or the acquired TTP, especially if it's a lupus, for example, certainly affect the kidneys. So it's also important to take into consideration as to what else is also affecting the kidneys.
Are you guys aware of any work that's being done to do AMSTS13 home testing? So a patient would be able to test at home. And would you recommend that?
I am not aware of any home testing for AMSTS13. We need to see if it's available.
There are testing platforms that we call.
Sorry.
No, I was going to say briefly, there are what are called point of care platform tests, which are like reading your blood glucose, which are being developed for hospital use. I don't think home use. And I think there may be such a thing as checking the AMSTS13 too often. So even if we had the ability to home test, I'm not sure it would be a great idea. What the ideal frequency to check it is not absolutely clear. But checking it too often could be an issue as well. You're going to see a lot of fluctuations and not a true trend.
There's a patient on here who flies from Bermuda quarterly to JHH, which I'm not sure what that is, but to get testing. So it seems like people are willing to go long distances to get this test.
That might be Johns Hopkins.
Oh yeah, that's probably it. Thank you, Spero.
I think I speak for most of our investigators in the USTMA that we'd be willing to go to Bermuda to take care of the testing for them if need be.
Yeah. So I'm trying to look through. There's a bunch of questions here. So if AMS13 testing is an important factor in determining relapse, why would you space it out for a year when the patient has been in remission for a year? So why do you feel like that is?
Well, I think what you're seeing is variability. And what I showed there, this every 6 to 12 months, is the recommendations from the panel of the TTP guidelines. Doing it more frequently is done in other centers. Our center, we will, in most patients, measure every 3 months. So that's where you see the lack of studies to say what is the absolute best way and what is sort of local regional practice to try to prevent relapse.
And how would a patient know if they had kidney or brain damage after a TTP episode?
So this is so one of the things when we check every 3 months, we don't check often. Or when you check the labs weekly and then monthly and then every 3 months, we check other labs to be sure that the kidneys are doing well, the liver is doing well. So if they have any complications or any affect the kidneys, we will be monitored from this point of view. If there is any brain problems or any cognitive problems, with the physical exam, when we talk with the patient, they can tell us, and there is some research going on to see the long-term complications in the brain.
That question was a great plant for the next topic that Shri is going to talk about, I think, and talk about some of these other measures of cognitive function that go beyond what we visually see.
And speaking of which, it is time to get her on board. Thank you, everybody, for joining. There's still a ton of questions, which we will have either answered in our Ask the Hematologist breakout session, or I'll fill them in other sessions as we're able to get them answered. So don't worry if you haven't gotten your question answered. We are working towards it. And I will now bring up Shirley.
Thank you.
Thank you, guys.
Thank you.
Thank you.